Hi class, welcome. I'm really excited today to be here with Dr. Eric Bing, Senior Fellow and Director of Global Health at the George W. Bush Institute. He's also a Professor of Global Health at Southern Methodist University, received his MD from Harvard, MPH and PhD in Epidemiology from UCLA, and also holds an MBA from the Fuqua School of Business at Duke. Thanks a lot for being here, Eric.
No, thank you for welcoming me to your class.
I wanted to get started by talking about PEPFAR. We recently passed the 10th anniversary of PEPFAR, and we've seen great success. One of our colleagues here has published an influential paper in JAMA showing all-cause reduction in mortality. In addition, we've seen 2/3 of the 8 million people in the world on HIV treatment are supported through PEPFAR, and a reduction in new infections around the globe, in the PEPFAR countries especially. So I wanted to sort of hear your comments on lessons learned from the PEPFAR experience and others like it.
No, thank you for giving me the opportunity to talk about PEPFAR. It's really one of the great successes that we've had in global health over forever, because it's just been so dramatic. When PEPFAR started, there were less than about 50,000 people on antiretrovirals in the world, in developing countries, though millions were infected. And it was really unclear on how we were going to combat this epidemic. And that's when President Bush decided to start the President's Emergency Program for AIDS Relief, and has radically changed the way we're doing development and global health, and has really begun to sort of spearhead a lot of these efforts, saving millions and millions of lives along the way.
Yeah, fantastic. When we look at the success story of PEPFAR, how do you think about the role of private agencies, the public government sectors that have been delivering care, and the relationship between them, as well as other players that have been sort of ancillary in the efforts? 'Cause PEPFAR has been supporting a number of different agencies.
PEPFAR has been supporting a number of different agencies, but one of the things that's really clear about PEPFAR is that the programs are really sort of country-driven and country-run, and PEPFAR comes in and supports those countries. The other thing that's also really important about PEPFAR is that it's not just the U.S. government doing it. It is really sort of showing the way. Private industry is coming in, other multilaterals and bilaterals supporting it, and then really big ownership by the countries themselves. Okay. So PEPFAR has supported efforts that are there, and has catalyzed an incredible movement.
Okay. You recently wrote a new book called Pharmacy on a Bicycle. Wonderful read. Can you tell me why you wrote this book and what you learned in the process?
One of the reasons that we wrote Pharmacy on a Bicycle, so it's Pharmacy on a Bicycle, Innovations in Global Health, Pharmacy on a Bicycle, Innovations for Global Health and Poverty. And really the reason why this was important is because there's been dramatic growth, there's been dramatic changes in the way global health has been doing. And we really believe that we're at a critical period right now in history, that with just a little slight change in the way we're doing it, so we can begin scaling up these programs that are quite successful, we can have even better success at saving lives.
When you think about scale and how we achieve that, what role does technology, and particularly mobile technology, play in helping us reach our goals?
I think technology, and mobile technology in particular, is going to be important in every single thing that we do in global health. Scale is just one of those. Scale in some ways is the end product of successful programs. Successful programs will need mobile technology. Okay. And let me explain that, and which is where I think the real advances that have happened in global health have occurred. The thing that we have begun to focus on in global health is understanding that our real need is to increase access to care. But access is not enough. We also have to increase use of services that we know that works. So we have to create demand for those services and have them be delivered in such a way that populations want them. We always have to make sure that we have good quality. And we have to make sure that the price is low enough that countries can afford them, so people can afford them. So it's access, it's use, it's quality, and its cost. All four of those are critical. And I think the real change that has occurred is that we are now using those as our outcomes. Obviously, the ultimate outcome is lives saved, but these are then sort of intermediary outcomes that is important for us to use: access, use, quality, and cost.
When you're looking to pursue those 4 outcomes, what is your starting point for designing either a program or a product? And I'm asking you because we have a number of inspiring students watching this lecture who are thinking about ways to solve global health challenges from some starting point of understanding a problem. When we then start to pursue what that solution might look like, I just would like to hear your comments on where they should start.
Okay. So to me, the end is always where you start. You start where you're going. So once you can find the problem that is a shared goal, that is a shared problem, you can then begin to work back about how you get there. And the reason why I say that it's a shared problem is that the whole thought of sort of a lone genius out there changing the world is no longer it's no longer a real thing. It probably never was. You just had one person getting credit. But really, the way we are going now is that you really need everybody. For advances in global health, you need people who are really skilled technicians. You need people who are excellent clinicians. You need people who are policymakers and understand how to get things done. You need community activists who are rallying people and understanding what needs to be done. You need entrepreneurs to figure out, okay, how do we get this? How do we make this work? You need everybody around the table to solve these problems.
Can you talk a little bit about the different people that you brought to the table for the cervical cancer program that you're working on in Zambia and how that fits in with what you're talking about and where it's going?
Absolutely. And so what you're talking about is, in some ways, the way we do business at the Bush Institute. We're an action-oriented policy institute. So we're based upon sound policy, good thoughts, good research. And for us in global health, that's our baseline book in Pharmacy on the Bicycle, explaining how we can use entrepreneurship, we can use innovation to create monumental change in health. Then we have to have action. That is our cervical cancer program called Pink Ribbon, Red Ribbon. Pink Ribbon, Red Ribbon is a public-private partnership that's supported by and founded by the Bush Institute, the UNAIDS, PEPFAR, as well as Susan G. Komen for the Cure, as well as a number of other public and private agencies and corporations. They have then come together to help catalyze movements in countries that want to combat their cervical cancer program. The first country we began with was Zambia. And the interesting thing about cervical cancer, as you know, cervical cancer is just a wart. It's caused by a wart, a virus that you can get on your foot. But this type of virus, a woman gets on her cervix. And you can diagnose the lesions so easily simply by putting vinegar, household vinegar, on the woman's cervix, and that turns into a white lesion that's very easy to detect by the eye. And then just like a wart, you can just freeze it off. And you can cure these women at the precancerous stage.
So it seems like there's a huge opportunity for mobile technology to expand access to this life-saving diagnosis. If we were able to do point-of-care diagnosis and perhaps even share the image more broadly to have other people sort of offer their diagnosis, then we could expand the reach to people where they are. Is this something you see going forward with the program? And if so, how will you achieve that sort of expansion into the regions where people actually live?
Okay, that's an excellent question. I think there's a number of ways that we use mobile technology in cervical cancer, but we can use it really in any disease. The important thing about increasing access, about reducing costs, is in task shifting. As long as you require highly trained physicians and nurses to actually do these diagnoses, to treat people, it becomes very, very expensive. And as you can begin shifting this care to not only new people, more people that are more common and less expensive, and to new places, non-clinical places, to even homes, you're able to increase access and decrease costs. And so that's actually what mobile technology will allow us to do in cancer, is to get these services out there. The thing about mobile technology, which is really kind of neat here in cervical cancer, is that you actually can just take a picture of the lesion, and that can then be used as a quality control mechanism. Like a nurse in the community can take a picture of the lesion. If she's not quite sure, she just text messages or sends it to the doctor. And the doctor can sort of look at it, and the doctor can say, I would do X, Y, or Z, and then send it right on back. Or you can conceivably even have these crowdsourced. So you sort of put it out on the web, and somebody who's trained wherever they are in the world could take a look at this and say, this may or may not be this. And there's ways that you can also sort of grade the quality of the person who is reading it. So even in low resource settings where you may not even have doctors who can read the diagnoses, you might have anybody in the world who could do it.
Yeah, that's super. And it answers what was going to be my next question, which is one that I've actually fielded from a number of people in doing task shifting work in the past, which people are concerned about the quality, about maintaining quality. And it's a valid and very important concern when we're shifting important clinical duties to perhaps less trained people. My response has always been that they're shifted to people who are able to deal with them efficaciously and competently. But how do we ensure that at more of a systems level?
Yeah, well, and so I think the more you shift tasks to lower skilled levels or to other settings, the more safeguards you have to have in place in order to ensure that things are being done properly. Because these lower skilled providers will be really good at doing what they're doing, but they may not be able to pick up something else. So you need to make sure you have the safeguards in there by having really clear standard operating procedures, exactly how things work, and then also ongoing supervision.
Okay.
And I think this is one of the ways that mobile technology will really help us aggressively do the task shifting, is because we'll be able to put that quality measure in place.
Excellent. Coming back to something you said earlier, starting with the end in mind, can you talk about that with respect to the cervical cancer program? The end state is relatively clear. It seems like there's a number of things that remain to be sort of evolved in specific ways, whether it's crowdsourced, and if so, how. But what is not yet done in terms of this project?
Well, so if you sort of think about cutting cervical cancer, really sort of ridding the world of cervical cancer, it's relatively doable because we now have a vaccine that can wipe out or women's susceptibility to get the virus. So therefore, while with visual inspection with acetic acid, which is what we've been talking about with the vinegar and the cryotherapy, that's one way. There are other ways of doing it, such as using more of a liquid-based cytology or DNA testing for the virus. But really, if you want to prevent it, vaccine. And I think, and that's actually, as we begin to sort of look at sort of mobile technology and how this can help, it actually can help in all of these things. Right. So it's not limited to one thing. It's limited only by our imagination. It's limited only by our willingness to work together. It's limited only by us saying that we can do so, but we have to do so together.
Yes.
If that makes sense.
Yes, completely.
One of the things that we often have within, well, we used to have, I think we have much less so now, because we've had such successes in global health because of this, is partnerships. So, just like you have physicians who in some places will think they know everything, you also have technologists who think they know everything, or policymakers who think they know everything, or activists who think they know everything. Well, yes, they actually do know everything about activism and policy and clinical work and technology, but really, and to solve the problem, we need all of us. There's nobody who has the one right answer, but collectively we can find the right answer. Technology, mobile technology is absolutely essential there.
So as we build these partnerships and integrate mobile technology into a broader ecosystem of care, can you talk a little bit about how metrics and a shared idea of the important outcomes is shared between the different people within the partnership? Because it strikes me, if the outcomes are so important, and it's important that everybody knows where the target is, and yet when you get a number of different organizations, even different types of organizations, public, private, that there can be risks that there's not a shared understanding in some cases about what is going on, what is being pursued.
Yeah, and I think having a shared understanding is as important in global health as it is in a healthy marriage. And if people don't come together and say, okay, this is our higher purpose, this is our highest cause, you're going to have failed projects, you'll have failed marriages. And so this is just sort of a human thing that we have to work on. And global health is no different. And so being really clear about those goals as well as what each partner gets out of it. And it has to be explicit to talk about it. So therefore, it's clear about what a partner needs, but also what they are accountable for in order to receive it.
So I want to take us now to Rwanda, something that we've talked about beforehand. Can you talk a little bit about what each person in the supply chain of care in Rwanda is getting and is managing in terms of the outcomes? So we have community health workers right up to the president, and they're all understanding similar outcomes. I wanted to see if you could talk a little bit about how that accountability is ensured and how that alignment is achieved along all different levels of delivering this care.
Okay. I think Rwanda is an excellent example of the way a system can work when partners work together at all levels. Because Rwanda was very clear that it wanted to reduce maternal mortality. It's unconscionable that a woman today should be dying during childbirth. That should not happen. Babies under a month old should also not be dying, but they are dying all over the world. And what Rwanda said is, no, we're not. From the top of the government to the village, to the household, they have made a commitment to combat maternal and infant mortality. So what the president does is the president has a contract with the local governors. And part of what they receive is based upon their success in meeting these indicators for maternal and infant mortality. So they're now motivated. They then in turn motivate all their hospitals and clinics because their compensation remuneration is based upon these same metrics. Then you have 45,000 volunteer community health workers that then go all over the country to make sure that women are getting prenatal care and that babies get the care that they also receive. So you have the entire country working. And to even make it even more integrated, you also have the communities who are also sort of looking to make sure that these women are doing what they're supposed to be doing because they also receive recognition when they have very low rates. And so everything then works. Mobile technology has also been a really sort of interesting way in how they're now beginning to make the system work. Because the goal is reducing infant and maternal mortality, then stuff sort of clears out the way in order to achieve that goal. So like the really kind of neat way they're doing using mobile technology is they're now they have these community health workers with their cell phones, and so when they go find a woman who's pregnant, they just ask her, "When was your last menstrual period?" And they then sort of punch that in. Text message goes to Ministry of Health. Then it comes back to them. This woman, based upon this last menstrual period, the person needs to come in for prenatal care here, here, here. She'll deliver here. Make sure she does it in a hospital or in a clinic, a skilled facility. And her postnatal visit is at this point. So right then, right when they're meeting the woman knows exactly what's expected of her. Totally neat.
Yeah, yeah. Phenomenal.
Yeah.
Phenomenal case study for other countries to learn from and from our students to think about how that can be replicated with other diseases. And
Yeah.
this is effective on a public health level and at the individual patient level. It seems highly customized and yet also effective on a broad national scale.
Absolutely. And I think you're right. I think even all these mobile applications have to be applicable on a large scale, but also needs to be customizable to local community needs.
Absolutely. That's something that many of our students are working on themselves because they come from many different places, and so they're working on unique challenges by understanding the local circumstance.
Yeah.
And it's been really enlightening for everyone. That reminds me of an earlier conversation we had about India, and specifically NH and Aravind clinics. So I wanted to hear your comments on how they've achieved such success from the operational side as well as the business side, but then the scale that they've achieved and how telemedicine has played a role.
Absolutely. And those are two excellent examples of NH, which does cardiac surgery, and Aravind, which does cataract surgery. Sound a little bit like, but a little bit different, but very, very different. And what they've been able to do is to achieve scale by incredible efficiencies, by really focusing on what a doctor can do and then really task shifting every single thing else. It's to the point where in Aravind, they have all the patients lined up, and all the doctor does is the cataract surgery. When she's done, she just raises her hand, and a nurse then degloves her and puts on new clothes, and she just turns around and does the next one. So all she does is like an assembly line. The way these two are different is that Aravind, cataract, is a nonprofit. NH, cardiac, is a for-profit. But they're still motivated by the exact same thing, providing care to poor people. And the way they do this is by being so good, they're able to attract people who can afford the care and will even pay more. And that's how they're able to subsidize the care for the poor.
My understanding is that they've used telemedicine to expand their reach in a great way, and they've been able to train additional health professionals throughout many African countries, which has led to a growth of their capacity, but also an exposure to patients about their services. And that has helped draw patients in while also building local capacity in those regions.
Absolutely. So one of the things that that NH was quite smart to do, and they were smart because they were driven by their desire to provide good care to poor people. They recognized that all poor people in India didn't live in Bangalore. Most of them really live in rural regions. So therefore, in order to get good care to poor, they had to be able to provide services in rural regions. So you could do that in a couple of different ways. You actually can physically move and do all your stuff there. Or because there's already infrastructure there, using telemedicine, they're able to then connect these clinics to their own program in Bangalore. So now you have 100 places throughout India that are getting the same kind of supervision of cardiac care that they would otherwise get if they had come to NH. In more severe cases, they're going to have to come in, but they're able to get some really basic care. They've not only done it there, they've also done it in Africa. You have 50 countries that are now, you have 50 clinics that are now connected to NH through telemedicine. And so the patients there get good care because they're now connected to NH. But also, what has then become to happen is that those who can afford to go to India for care, the Africans will then pick up and go to NH in India. So that then creates resources for NH to provide care for the poor even better there than India. They're now beginning to expand in the Cayman Islands. So they have they're about ready to build a $2 billion hospital based upon their program in India right there in the Cayman Islands, which is just 30 minutes from Miami, which will really begin to then attract people from North America and South America to their program. The one thing that's also, why would they be attractive? So one of the things really is quality, but the other major thing is cost. In India, they can provide a cardiac procedure for 1/5 of what we charge here in the United States. Huge cost savings. Don't know if they're doing that in the Cayman Islands, but this is to be seen.
Wonderful. Thank you so much for being here, Dr. Bing. It's been
No, thank you. I really appreciated this.
wonderful chatting. I think that's a perfect way to conclude, to have a final reminder to focus on the outcome, focus on why we're doing this work at all.
Absolutely. And just, the other thing that I would also say, most of the things that I've talked about today are in my book, Pharmacy on a Bicycle. And so if people want to know more, they can just check it out. It's on Amazon. It's in Barnes & Noble, anywhere they would like to look.
Perfect. Great. Congratulations on that as well.
Thank you very much.